describing the profiles of our great speakers, because you have that information on your programs. I would just like to say that I'm really excited to have them here because we have a great mix of theory and practice. In fact, we have one of the members of the panel is a representative of the private sector, which is great and refreshing to have in these discussions. I would also like to thank Cardno for supporting this session, and to Ron Ashkin in particular, who's going to be one of the speakers, for his collaboration in helping me and the Beam team to put this panel together. And of course, to the speakers and the moderator for their effort and generosity. So welcome everyone. Before we start, I'd like to remind you to, whenever you have an insight or a suggestion to follow up, to write it down and leave it on the table at the end of the session. Also, we have this list here in case you want to continue engaged in this conversation, which we hope we're going to promote from the Beam Exchange, to leave your name and email there so that we can contact you after. Okay? Without further ado, because we have limited time, let's get started. Ben, I would like to welcome Dr. Ben Taylor, who's going to help us with the
Thank you very much.
and the commenting of this session. Welcome. Let's give him a round of applause.
Oh, thank you. Thank you. Right, just a couple of quick slides from me to sort of set things up, and then we're going to hear about one program and its partner from the private sector, which I think is quite exciting, and then from another program in health. You're going to be asked not just to ask questions, but to participate and answer questions as well. So hopefully it'll be quite an interactive session. However, we do have a very, very hard stop because one of our speakers has a 2:30 flight, so they're going to have to, take the highway, I think. Right, so who was in my session yesterday? Yeah, there's a few of you around, but basically we talked in a session yesterday about the new frontiers for markets or systemic approaches to development in health, education, water, and in financial health as well. And so this is basically focusing more intently on one of those sectors, and it's Welcome to the Future 2.0. This is the right. So some of these are extracts from one of the programs in particular, but the concluding point of yesterday's session, and you just have to trust me if you weren't there, was that the M4P in health, like in the other sectors, is possible. There are examples out there, and you'll hear some of them today. It's difficult because there are similar but also different challenges in terms of politics that aren't as prevalent in other sectors. And it's very necessary, and we spent quite a lot of time yesterday looking at the severity of the problems in these sectors, which are striking. And the idea that we've spent so much money over the last 50, 60 years and generated so little impact in these sectors is remarkable. So we have to try something different. So this is a quote from the annual review of PSP4H, which is one of the programs that we're going to hear about, that the fundamental M4P market systems framework of a pro-poor, facilitative, systemic, sustainable, scalable approach, it's catchy, does not need to be radically altered to operate in healthcare. Basically just saying it applies, it works. You just have to employ it and use it in your own way, in your own context. And that also, this is another extract from the, this one's not a quote, but that pluralism is key to improving health outcomes because, as we talked about yesterday, recognizing the realities, the hidden realities, it's all very well saying healthcare should be publicly provided, but it's not. It's not, so we have to make it better. And also, similarly, we're not on some big privatization kick. Actually, the programs we're hearing about today do talk more about the private sector, but there are other programs, other little initiatives that are focused more on improving public sector delivery, but using a systemic approach. So these are other sort of talking about the relevance of M4P in health. It relates to SDG 3. SDG goal 3 and 8. So it's a methodology, not an ideology, and as I'm saying, it equally applies to public sector, pluralist approaches. It is inherently pro-poor, supports system strengthening. It measures the impact, so we can actually show this over time, although it's kind of early days, so we don't really have huge results to report on yet, although you'll hear on a couple of very good cases today. And it's also a kind of, it reduces the out-of-pocket expenditures, so you can actually look at it from an income perspective as well as from health outcomes as your top of your theory of change. So without further delay, let's get into the programs. So Ron is going to talk about PSP4H in Kenya, which is one of the innovative programs in the sector.
Well, thank you for coming today. I wanted to relate this back to Jim Tanburden's. I don't know that I even need the mic. I don't think I need it. Oh, okay, sorry. Jim Tanburden's plenary yesterday, he asked 2 questions and made a couple points I wanted to relate to. He said we need big wins. Today we have the CEO of FarmNet here, and we're not there yet, but as far as I've seen and what I participated in, he's the only private sector participant here, but he represents an association that already has hundreds of pharmacies networked together, facilitated by PSP4H in Kenya. So it's big and it's started big. So that's one, to address Jim's point. His second point is, can we do market systems programs with big companies? And yes, we can. In PSP4H, we have a partnership with GSK, one of the world's biggest pharmaceutical companies. So here's a program that actually applies and answers a couple of Jim's points. What is the program? Right now, it's the only dedicated M4P in health program in the world, and it's funded by DFID. We're a research program. We're not a delivery program. But 80% of our research budget is action research. It's not just desk research and surveys. So what we do with most of our budget is engage with private sector partners to test business models. And the whole point is to inform future programming. And we'll get to that at the end. The problem there is the program's done really, really well. In some ways, it's a Trojan horse inside DFID's very public sector-oriented health world. But I don't see any other business cases coming out saying do more of these. So our imperative for the group or for this whole 200-person session is to get more of these going because it works really well. Healthcare is really crowded. When I got to Kenya in 2013, we did a donor mapping, and there were 273 donor-funded health programs in Kenya. Okay, but our domain's actually unique. We're pro-poor, like DFID's mandate is poverty reduction. So by definition, we're pro-poor. We're engaging with the private sector, but that also means NGOs and faith-based organizations. It just means not government. But we only engage with the for-profit or commercial private sector. So our domain's actually unique. So those 273 programs, we're the only one that fits in that space. What's the healthcare system look like? Ben talked about pluralism. So in health, you've got public sector delivery, you've got PPPs, you've got the private sector, but the whole thing has to work for the system to function. And to put it in the M4P who does, who pays framework, it makes it pretty clear. Public sector does and pays in public sector provision. In PPPs, public sector pays, but private sector does. And down at the bottom, it's private sector payment, private sector delivery. So we mostly work down there, mostly in the bottom, but up in the public-private partnerships. That's basically where we work. When I talk to the development community, all private sector programs are the same. So these privatization things Ben alluded to are the same as the market systems approach if you don't differentiate. And healthcare tends to have a very public sector orientation. They don't really look deeply at this, but basically private sector means different things depending on objectives. And health tends to be top-down driven. You decide in Geneva or London or New York what the agenda is, and you basically do direct delivery. So external agendas and grant funding. The private sector basically consists of government contractors. Okay? On the other hand, if you've got consumer-based agendas or bottom-up agendas, you have market-based funding, you actually get commercial players moving into underserved areas. Excuse me. What it means is if you do it directly, no sustainability, you have to keep funding it, and market systems leads to sustainability. So I differentiate types of programming by methodology. Now, what's our approach? Basically, we're all TA. The program gives no grants. We have no funding at all. Not 10 bob goes between us and any of our partners, okay? We have a defined process, and it's on our website. which I'll give you at the end. It's psp4h.com. But we have a defined process. Interventions go through a process. It's process-driven. It's consulting. It's not, we decide every day what we're going to do. We use a screening model that goes through relevance, impact, engagement, and do no harm. And it's a logic model in order to get through the intervention. So we design our interventions to be pro-poor from the beginning. And the reasons things don't get into the program are basically they expect money from us, they won't share data, or they're not pro-poor. Because there are all kinds of cool medical technologies out there that are not pro-poor. They end up at the top of the market. Everything has the results chain, but we use clear, simple logic. But every intervention and every intervention manager has to understand this. We don't have a spaghetti bowl at the top and nothing at the bottom. So every intervention has to be logical. We do follow DCD standards, so we have measurement plans embedded. But we're very street. It's very much a street-focused program. We understand a lot about behavioral economics. We've done a lot of research into health spending, health-seeking behavior, path to treatment, how consumers actually behave. Again, all this is on our website. We also understand appropriate incentives to the private sector. So that's basically a real quick look at how we approach the market. What have we learned? Basically, by using the bottom-up approach, we have a lot of market insight. And we found, even though there's 273 health programs in Kenya, they're all crowded into the same corner of the field. So they're all doing what we call the ATMs. It's AIDS, tuberculosis, malaria. And then DFID has a women and girls focus, so they're family planning and maternal health programs. So if you stay out of those 5 areas, nobody touches the poor. So there are no donor programs in these areas: diagnostics, demand-side health finance or health insurance, low-cost delivery systems, the engineered model used in India a lot, non-communicable diseases, pharmacy supply chain, and we'll see a great example of that in about 5 minutes. We've quit calling people poor. It's actually the mass market. In Kenya, 83.3% of the population works in the informal sector. Insurance for that population is in the single digits. So basically, you've got a very cash-savvy, cash-mobile population that are not in the formal sector, don't have insurance. I talked to GSK about this in a market research we did, and they said, those aren't poor people, that's the mass market. We're only serving 5%. We want to figure out how to get the mass market. So the way business looks at it is different than the development world. It's not, oh, those poor people. It's an untapped market. So they really do look at it that way. Partner engagement is key. Obviously, in our screen, we don't just do analysis. We only intervene where we have partners that will invest in the intervention, where they'll give us data, and where we have mutual objectives. We've learned not to create anything. I think a lot of us know that. So we go with existing initiatives. We support early adopters. We leverage networks. We found a huge amount of play in using professional associations that were clinical but not business-oriented. And we preach avoiding money to create incentives, because money is its own incentive. We only do TA. So everything we do is invested by the partner. In FarmNet, for example, all the members pay fees to be in the franchise. We don't pay them to be in it, so we haven't capitalized them. Now, here's just an example of some of our interventions. In Kenya, the path to primary care is basically self-diagnosis, self-treatment. So 70% of the time, you go to the drug seller. More than half the time, it's illegal. WHO estimates 30% of the medicine in Kenya is bad, but at the bottom, it's really a coin toss. It's 50-50, because at the top, it's 0. So there is no connection with the physician, the proper consultation for poor people. What we've done is we've worked with, first, the Kenya Medical Association. We've put together DocNet, consulting physicians. We've worked with ACAMOSO, the Association of Kenya Medical Laboratory Scientific Officers, and put together LabNet. And we've worked with the Kenya Pharmaceutical Association, which represents the pharmaceutical technologists and runs about 90% of the community pharmacies in Kenya. We've put together FarmNet. Surrounding that is AfyaPoA. It's a health insurance, health savings system that works on a mobile platform, but it's designed by Juakali. It's designed by the informal workers for their needs and their spending patterns. So through the program, and this is all facilitated, we've put together a closed loop on correct path to treatment, all through the private sector. Okay, now the nice thing about it is everyone to be in the professional association has to be licensed and registered. So now on the provider side, everyone in these networks is already within the regulatory framework. So now we've got private enforcement that leverages the public sector's ability to bring quality care. Okay, and Jesse's going to talk a lot about FarmNet. It's really going well. It's on its way. LabNet, when we introduced LabNet last year, the East Africa Community Laboratory Associations were all there. On the spot, they demanded LabNet for the region. So they signed an EAC-wide MOU for LabNet, not only in Kenya, but now in Tanzania, Uganda, and Rwanda. And in Uganda, they started already. Okay? The DocNet, actually the Kenya Medical Association approached us. So if you want to talk about demand-driven, we didn't approach them, they came to us. They said, based on FarmNet and LabNet, we want a doctor's network. Can you help us? So we just launched that. A few weeks later, we were talking to Swiss Development, and they invited us to see if our model works in Somalia, where basically nothing works. And on the spot, the Association of Private Medical Schools in Somalia wanted to do a DocNet. So we're in the process of getting it going in Somalia. So the concept works, it's demand-driven. You can ask Jesse about this later, but FarmNet was planned as a pilot. We planned it to start at scale. We planned it to start at 100 in Nairobi and Mombasa just to prove that supply chain would work. But all the members demanded to be in. So we had to call the pilot off. It got up to 250 almost overnight. All this serves low-income consumers. The whole point is to bring value for money, quality care to a low-income audience that right now is getting a raw deal. And unfortunately, like Ben said, we need a pluralistic system. Health is very politicized. People in the donor world said we should have universal coverage. It should be publicly provided. Unfortunately, as an economist, the economy of Kenya cannot support that. And the reality is that, like it or not, poor people are cash savvy and cash mobile, and they do pay for care. So this is an attempt to give them value for money, quality care, path to treatment in their neighborhoods, and it's working really, really well. So what are the approaches we're exploring? Basically, we're trying to use network synergies as a way to scale up quickly. And I think if you were in another session yesterday, you heard a lot about starting at scale. This is another example of starting at scale. We're not doing an EEE pilot and boom, magically it's going to scale up overnight. We started, like I said, with FarmNet with 100. We've got almost 500 pharmacies trained, and we're still trying to bring some into the network, but 250 branded, over 300 paid their fees, and over 500 trained to bring it to the network already. So we're trying to start at scale by engaging with networks to take advantage of aggregation advantages. We're using a portfolio approach. Again, I'm not the only one at this session using that approach, but basically we don't time the market. We had a broad mandate. We did an honest donut looking at the whole system. We found not only relevant interventions, impactful interventions, we found partners willing to engage. So we have the tiniest budget in DFID's entire Kenya portfolio, but we got up to 18 interventions at one point. Okay, so we're down to 13 because some of them were not going so well or we couldn't get data from the partners, but 13 are going and they keep coming in even though our program's progressing. So some have died off, but what we found is we started with simple logic. We didn't try to over-design the system. We found they overlap each other when we start to have outcomes. So for example, working with low-cost clinics, they all have pharmacies, so they become members of FarmNet. They all also become providers for the insurance network. So instead of designing the market to work all at the beginning, we work with simple interventions, but at the time, the business model started to change, to actually converge. Okay, so we're dealing with that now. Also, we've used a quick intervention model because when we started doing a lot of your basic plotting, get ethical approval, do a survey, write some reports. We get these 50, 70-page baseline reports. Now what we're doing is we just talk to the partner, we come up with a hypothesis of why the system's not working, and we experiment. So we're going more into quick interventions. In fact, I can relate to Springfield training when I was a student there, and the session was about working in conflict environments, and the instructor said, well, it was a conflict environment, it's unstable, so we had to do our assessment quickly. So silly me, I asked the question, because you did it quickly, was it any less accurate? And it's like, well no. Then why don't we do it quickly all the time? So we've actually gotten to that, to where we just go right to the hypothesis based on the secondary data we have already, and it's working really well. This is disruptive innovation. But it's disruptive to people that tell you that you've got to spend a lot of money to change the health system, and it's disruptive to people that say you've got to have technology in there somewhere. The innovation is in the business model. And I separate out the technology from the knowledge of the political economy. Because the technology might work in India, it might work in South Africa. Those models have consistently failed in Kenya. What we've done is work with people who understand the political economy, and the thing just hasn't been done yet. So the innovation is not what people think. All right, but over and over again, you hear, oh, it's got to have a microchip in it, it's got to be mobile. Oh, we can't do that. We need to fund it. We need money. None of that's true. We haven't funded any of our interventions. And in fact, one of the least successful areas we've worked in is mobile health. And that's probably the heaviest funded area of health innovation. Okay, here's our contacts. Especially look at the website, pspforh.com. We've got more than 50 reports, policy briefs, intervention notes, case studies. And it's all public domain. We've got a LinkedIn group. We've got a Twitter feed. So thank you.
Yeah, I just wanted to remind you of the structure of the session. So we're now going to hear from Jesse, who is the CEO of FarmNet, which is one of the interventions under PSP4H. And then if you can ask any sort of quick clarifying specific questions about the program or about this intervention, we'll go through them. Then we'll go on to a different program from Kabir about SunMap, which is a malaria prevention program in Nigeria. And then again, we'll do quick clarification questions, and then we can move on to kind of draw them together and bring some more general questions out. Okay, over to Jess.
Thanks, Ben. Good morning. My name is Jesse, as you said. I'm the CEO of Nairobi Tech Farm Limited, which is a child of PSP4H partnership, even though the idea was initially with the Kenya Pharmaceutical Association. And as we come in as a network of community pharmacies, what background we bring? One, we are here to attest that professional associations basically has a role to play in meaningful delivery of services in our various communities. In Kenya, we have 8,500 regulated pharmaceutical technologists practicing pharmacy in Kenya, and prior to formation of this network, they were practicing differently and separately and competing with one another. We are engaging them to ensure that they don't compete, but they begin to explore synergies. Out of that number, we have 4,000 of the 885 doing actual community practices. They own and they run their own pharmacies. They buy medicine every day. They decide on what qualities of products to buy and what not to buy. If they decide to go for counterfeited products, the choice is theirs, because those are their businesses. If they decide to go for low quality products, the choice is theirs, because that is their business, and if it gives them profit, so be it. So that is the background that we're coming from. And most of these pharmacies, as Ron has also alluded to, basically they practice in the mass market, in the areas where the low-income members of our communities live. These people can buy medicine. However, they don't have the choices of the products to buy. What they have within their communities are either products that have been counterfeited, products that are expired, products that have been brought in as parallels, products whose qualities cannot be vouched for. So predominantly they operate in those areas. And in our network, as we are putting together FarmNet, we started by a process that I'm going to show next in later slides. But we already have 250 pharmacies operated, our members trained, and the pharmacies branded. That means they are fully converted into the network. They are willing to replicate the policies that we are sharing with them, especially on quality. We train them on business skills so that they don't just see pharmacy practice as simply buying and selling, but it's buying and selling quality assured products using the knowledge that they obtained from their training in colleges. Now, what does FarmNet stand for? What were our reasons for bringing in FarmNet? One, we thought, as I've just shown us in the previous slides, that as a whole group, if we were to come together, we would have the advantages of synergies. So we said it's good to have a self-regulation as a professional association. One is important for us because Kenya Pharmaceutical Association, who is the owner of FarmNet, is regulated by Pharmacy and Poisons Board, which actually works on behalf of the Ministry of Health. So that is the statement that we're bringing, that self-regulation is beginning to happen at association level. So any member of the association that's practicing pharmacy goes through that. Now, our reasons for doing this were to improve access to medicines, to alleviate the cost burden of medicines that were being passed down to the consumers. Incidentally, before this network was put in place, we had essential medicines, some of them going to the consumers at a markup of up to 500%. And that makes it nearly impossible for them to access those products. So through the network, they are able to have prices brought down just immensely to help them access those products. And this is a very huge reason why we thought this should be done. Now, incidentally, the illegal pharmacy practitioners sell at very low prices because their products don't follow any quality, and they sell anything. They can't tell you where they've gotten them from. There's no traceability of those products. Some of them are stolen, some are fake. So that was a challenge to our members, because as long as you are practicing with someone in your neighborhood who is selling products that have been shoplifted from somewhere else, they are willing to give it as nearly free as possible, then you are out of business. So one problem we had is professionals were running away from pharmacy business because non-professionals were doing better business in their midst. Now, support of KPM members willing to train in business skills is a huge advantage, a huge reason why we started FarmNet as well, because we also discovered that our members, prior to coming from pharmacy school, all that they know is pharmacy and medicine and health, and that's just about it. Nothing to do with customer care, nothing to do with inventory management, nothing to do with business skills at all. So we basically bring them in and say, look, we need to go through refresher trainings on business skills so that you can be in the marketplace, you can be able to explain to your clients how they ought to use the medicine. Where we come from in Kenya, we have most practitioners basically labeling medicine as, take this 1 times 3. It is 1 times 3, 2 times 4. Now, 2 times 4 doesn't make any sense to a consumer. It probably, I was talking to someone who said it might mean 2 times 4, I wake up in the morning, take my first 2 pills. Go for breakfast, take the other 2. After breakfast, I take another 2. Before I drive out to work, I do the last 2. I've done my 2 times 4, and I'm through with my medications. Now, that is what the members of the public have been going through. And why did we have this? Now, the reasons we said is that we recognize that pharmacies are the first place of call for medicines when it comes to medications. When low-income people in Kenya when they feel that you have a fever, the first place you run to is to a pharmacy next door. And I think it's not just in Kenya, it's not just a practice within the low-income communities. In most countries, when you are unwell, the first place you run to is to your pharmacy and ask them, I'm having this fever. And then they will have that liberty to advise you to go for a medical checkup if they're not going to give you, if you don't want to self-medicate, if you don't want to have an over-the-counter medicine. Now, in Kenya, it is a huge problem because the whole cycle of treatment ends at the pharmacy. Why? Because these people don't want to go out to a medical facility and pay more for that. So that was a reason. Now, consumers cannot differentiate between regulated and illegal facilities. Therefore, they would buy. They actually were buying from anyone who opens up a facility and says, "This is a chemist, this is a shop, this is a pharmacy." So they'll buy from there, whether you're trained or not. The risk is with them, but they don't know for ignorance. And then we have most pharmacies in low-income communities are illegal. Nearly 2 times of the regulated pharmacies in Kenya are illegal as regulated. I hope that's clear. So if we have 4,000 pharmacies regulated, about double that number are irregular and not regulated. Now that is a huge public risk, it's a health hazard. And then we say the cost of medication, as I've mentioned earlier, is not regulated, is not controlled in the retail market. So I sell at whatever price I want to sell. And that simply meant that the consumers out there basically were presented with a problem that they cannot mitigate. They actually have to buy at whatever price. And we have cartels, we had cartels doing that. And so it was a scenario where those who have money are going to stay healthy. Those who don't have money basically would go without medicine. Now, in our process of forming FarmNet, we go through this. We have the quality training I've mentioned, and when we train, we bring our members back into a classroom setup and tell them of the quality. We have a quality manual that we share with them. And after doing that, this is the process of branding our members, so that we say, now this is a quality assured pharmacy in a neighborhood. Following quality training, we go to branding. So we brand them next, having paid the memberships, having signed MOUs that they will adhere to the regulations that we have in place. One of the regulations is that they must buy through a system that has been validated, so that we have traceability of the essential medicines within their facilities. And then after branding, our branded facilities look something like that. After branding, we go to pool procurement. The pool procurement approach is an intervention within this intervention to ensure that the products that our members are getting are price controlled. The price can be managed. If one person can buy a product at $1, 10 of them would actually spend $10, and 250 will spend 250. Now, if we can do that, if we can consolidate that, which we're already doing, we are able to get better prices for these facilities, and those better prices are translated down to the consumers, and the consumers are beginning to see that they can now get quality assured products within their communities and at prices that they can afford. After that, after pool procurement, we go to quality audit. Now, this is a periodic exercise that we do within our system to make sure that every person who is participating in the network adheres to the qualities of the network, and the circle continues on. Now, that is our strategy of making sure that the network is watertight and is based on quality. The shared logo of FarmNet comes to us as a client signaling for the public. They get to know that there is a quality assured facility in my neighborhood. I don't need to go 10 kilometers away. I can buy from here, and I'm sure of the quality of that. It also communicates consistent standards. It communicates quality assurance. It communicates that there is group purchasing approach that is being employed in those facilities. Therefore, the costs are fairly predictable. What I bought in one corner of the country yesterday, I can buy at the same price at a different corner of the country without compromising the quality of my healthcare. So that is what this brand logo represents. We have Kenya Pharmaceutical Association, which points at regulation, and the network brings trust to every person who comes into our facility because they know that we have those periodic audits. Now, this is what we had prior to branding. Our pharmacies looked nearly something like that. It's a pharmacy where it has all colors, and it is the only one in the country. Therefore, whatever we get from this pharmacy called Roll and Ralph, we cannot get from another pharmacy, and the invoices cannot be exchanged. Any medicine I get from here cannot be replaced for me anywhere else. So that is one. Now, following branding, we come up with a branded pharmacy with this logo. Whatever I buy from any branded facility can be exchangeable for me in another pharmacy that is a branded Farmnet. Now, what does that mean to us? It means, therefore, that the quality system is fairly watertight. The process of putting this in place is fairly regulated. If I am messed up in one pharmacy, one network pharmacy, I can be able to seek recourse from the association, from the regulator, or from the administrators of the pharmacy, which Farmnet really is. Now, following successful branding of our members, what are the benefits that they have? The members that are branded, the members that join the network enjoy marketing as a group. Incidentally, PSP4H gotten into this partnership with KPA because we had the numbers. If it was only my pharmacy, I think David couldn't have allowed them to come and offer this support to me. So there is the marketing approach, there's training that we do to them periodically. We have quality audit, I've mentioned that, and then purchasing and advocacy. Advocacy also talks about telling the public, letting the public know why these pharmacies are within their neighborhoods, that they are not in those neighborhoods just to make business, but they are in those neighborhoods to ensure that the quality systems, the quality products that are gotten from those facilities are attested to by the regulator. Because by and large, it is the regulator that decides whether I hold a practicing license today or not. The association only gives me a clearance to go and get my license. So those two tiers ensures that anywhere where this brand logo is, there is that support and we can be able to move forward. Now, my conclusion. I've mentioned the regulator, I've mentioned the association, I've mentioned the independent members, but here is the end of it, that we can only have these successful approaches when we have development partners where we have PSP4H not working in isolation and not pushing it down our throats, but discussing with us what we need to do and what we have, and not giving us money to do a project, but helping us appreciate that we can do it ourselves so that we can do it. The regulatory system comes into play where they say, okay, look, this is what we have for you, and these are the regulations that you must adhere to. There's nothing out of it. If you go out of it, you fall over. And then there is a professional group that comes into play to ensure that there is peer support of whatever intervention that's happening. By the end of the day, it is the businessman who must continue making his profits as he serves the community of the low-income persons and those who have the means to buy the medicine. Ladies and gentlemen, we hope that we can move forward and build effective and accessible markets. And as we do that, we must work towards intentional partnerships devoid of handouts. Farmnet has not gotten any handout from anyone, but we are glad that we are doing what we ought to be doing by technical support that partners have really given us, and not just spoon feeding us. I think that's the way to go. If we are to change our communities, if we are to change the marketplace, if we are to bring in the inclusivity that we really would like to have, I would want to say this is the way to go. Thank you.
Right, any quick of PSP4H and Farmnet? Anything that's more general about health? We're trying to keep about 20 minutes at the end so Kabir needs 15 minutes or so to go through his slides. So, literally 2 minutes now. Right, go left to right.
Do I need to say that or I don't need to?
Yes, please.
All right. Thank you so much for this inspirational information. I just have a quick question, actually, and it relates to what Jesse said and what Ron mentioned earlier in terms of pro-pool approach. And I understand there's a lot of quality, safety that has been the fundamental aspects of this joint venture. But how does it address the issue of accessibility? I haven't seen anything related to that now in your presentations, to both of you.
One thing I said is our pharmacies are located in the areas where poor people live. So already there are participants in the neighborhoods where the poor live. I've alluded to, when you're talking about access, I've alluded to our pool procurement approach, where we actually ensuring that there's quality, yes, but it's quality at access prices, at negotiated prices, and those prices are sent back to the poor. So basically, that's providing access. Yeah.
Susan Payne, Barclays GSK Partnership. Jesse, thanks very much for a great presentation. My question is about your pooled procurement practice, PPP. Does FarmNet buy the medicines and then on-sell them to your members? Is that how you manage to negotiate with the manufacturers? Or do you just facilitate the price reduction? And do any of the manufacturers give you discounted prices? Thanks.
Yes, in our pooled procurement approach, all our members, they channel their orders through FarmNet, through NTP, and then in that way we negotiate prices for them on their behalf from the manufacturers of those products. Yes, we have arrangements with certain manufacturers, and we are getting access prices.
Now, just real quickly, KPA owns a company called Nairobi Tech Farm, which is a commercially registered for-profit company. So they have an internal pooled procurement company. And the model is like a virtual warehouse. We use the existing distribution system, so we haven't set up a parallel distribution. So it's basically buying and selling on behalf of pooled needs of members.
All right, thank you very much for these presentations. I was struck by a few remarks you made. Jesse, you said you actually mentioned development agencies as stakeholders in the system that you work with. And from Ron, we heard that you set up FarmNet, DocNet, and the other one, and well, Jesse says you did not get handouts. So the clarification I would still like to get is the process of building ownership over FarmNet. Who actually has the ownership of FarmNet, and how was that done?
Thank you for that. FarmNet is owned by Kenya Pharmaceutical Association. Incidentally, when PSP4H came into the scene, Kenya Pharmaceutical Association already had the idea, and they had already incorporated a company to do that. However, for lack of resources, for limited resources, when PSP4H came in, we had discussions with them, and we said, yes, they can help us with technical support. Now, this has not been in monetary or in anything. It's technical training, development of materials, helping us to get basically experts in areas that we were exploring. And because they are research-based, also opening to us the researches that they're doing, so that we can be able to carry out a project that is watertight. But basically, it is a KPA idea. It's Kenya Pharmaceutical Association that has started this, and that is running with this. So we don't get any handout from anyone.
No, thank you very much. That's a very good presentation. My question really is about the reception that your members have after the branding. Have they seen increase in business? Have they seen any real impact in terms of bottom line impact? Beyond that, you described that the pharmacies that steal things and sell at really low prices. How have they responded to this? Has there been a movement from them to join your network, or is it that there's a regulatory authority that basically shuts them down?
Right. Great. Yes, the reception by our members has been excellent. When we branded our first facility, the legal practitioner next door closed down. because they realized that there's a quality assured facility coming in the neighborhood, and there would be regular interaction from the regulator, so they closed down. Now that is an impact that we saw, but that is basically on the illegal practices. But then going back to the bottom line, I mean, our members, yes, attest to the change. I mean, they're beginning to get more business, because once the public has been educated, once they've been told that, look, you have two choices in your neighborhood. One is regulated, another one is not. One has a qualified person, the other one does not have. And then they look at the pricing and they find the pricing model is actually better, if not similar. Then the choice is clear. So they're beginning to make more business. Yep.
Okay, so if you have any further specific questions, you can email Jesse and you can email Ron. Take it up with them. We're trying to get some more generalizable learning out of this session, so if we can then go to Kabir, hear about a different program, and we'll ask and answer, hopefully, some more general questions about health.
Okay. Hello, my name is Kabir. I was on SUNMAP before, a DFID-funded project on malaria, but currently I'm with the Solena Group. We do management consulting in healthcare. So what I'll be speaking about is the political economy in health market systems, expediency versus sustainability. This is trying to give a sense of how the environment around the health market systems affects, can I say, the private market. The overall environment affects the private market. Well, let's get onto it. SUNMAP was an eight-year DFID-funded project supporting malaria elimination. We divided into two broad departments, or the public sector side, which was engaging directly with the state and federal government, and the commercial sector side, which was trying to develop market systems for three malaria commodities. There were LLINs, which are the mosquito nets. There were ACTs, which are the artemisinin combination therapy with the malaria drugs, and the RDTs, rapid diagnostic test kits, which are the test kits for malaria testing. And we'll use the M4P approach in the commercial sector side. So now, trying to define the political economy, or want to set the context. Now, over 60% of Nigerians seek care through private channels. These private channels include private hospitals, community pharmacies like Jesse's, FarmNet, but we don't have such a network in Nigeria yet, and patent medicine vendors. But majorly through patent medicine vendors. There are over 200,000 patent medicine vendors in Nigeria. Community pharmacies are probably around, they're less than 10,000. I know registered pharmacists in Nigeria are roughly 19,000. And well, I don't have the stats for the private hospitals just yet. Now, malaria kills about 300,000 Nigerians annually. And the National Malaria Elimination Program has a plan to eliminate the disease by 2020. And so different development partners came on board with their own mandates, not fully aligned with that plan, because that plan came on quite more recently. It was about the 2014 plan, whereby but some of these partners had been on board much longer. So talking about expediency versus sustainability now, expediency here is is speaking to how partners want outcomes to happen now, rather than thinking about it in the long term to make sure that things are sustainable. So of course, by the time they pull out, you know that the markets are there, everything is working fine. So I'm going to give like two tales of two commodities. Now for the mosquito nets, what we found out that the private market players were weak. These are really small guys that really didn't have the ability to do any form of real marketing. So they were just really running small sections of the market. Then the consumers we also found out that they were not really willing to purchase the product. They had various reasons for that. Probably some of them it was cost. Some people had various myths about the product. Then subsidies and pilferage squeezed out this commercial market. Now this pilferage essentially came from commodities that were purchased by the government, housed in government warehouses, but then moved out through the back door coming into the market. Now, you would then find out that some of these commodities were then being sold at about 5 times less than the standard commercial prices. So that would really affected the activities of these the commercial players that were in the market for profit. Then the private market players were also not engaged at high level decisions. This, when the malaria elimination program has some activities that they want to do, they'll be speaking to the very big boys, the WHOs, UNICEF, Global Fund, and all the major products, without really thinking about the effect of what they will be doing on the private sector. The private sector would not be called into those discussions to have at least to have a say in this. So, and there was also lack of harmonization and ineffective communication at the government level. So that in such a situation, what I'm trying to say here is different partners doing different things, thinking they are all going towards the same outcome. But rather than having that harmonized setting at the very top, where you can then say, okay, Mr. A, you go this way, Mr. B, you go this way, because all activities will then lead to a specific outcome. But then we now move over to the ACTs. The market was not really developed in the rural area before our interventions, and the mandate really for SUNMAP was to try and get these products into the rural areas, which is where we see the highest burden of the disease. Guys in the urban areas, they could afford products. They really had more information, but the rural areas were the real challenge. Now, I said urban demand was available despite the high prices. Then the private market player then created that niche for themselves in that urban market because they could see the market, they could see the system, and everything was working fine. Now, expediency here, I said, brought about increased supply of children doses. Now, there was this program in Nigeria called the AMFM, Affordable Medicines Facility for Malaria, funded by the Global Fund, and that was meant to subsidize malaria products, malaria drugs in the country to make it more affordable to the rural market players, so that at least they can then there'll be increased uptake of the product, so they would use less of the monotherapies that are not very effective. The AMFM program was quite successful. There was a lot of supply of the product, but then there was a challenge that then came about. It was targeted mainly for the children, but there were also subsidized adult doses. But now the adult dose is 4 times the children's dose, and you then find out that adults are then using the children to just take 4 times extra. But then the consequence of that was then the overtreatment of the disease. Now, on the market system side, we would look at supply of the drug, letting it being available in all corners. We look at that, yes, we are really doing good. But we then need to look at the flip side, that if that drug is very well available at a very low price, given the fact that we are running in a society where people self-medicate a lot, the first point of call is the community pharmacy, or in this case, the patent medicine vendor that doesn't even have any education about healthcare. That is going to be a problem. So I think that is something that we really need to look at and think about in the healthcare systems when we are trying to design intervention, when we're trying to design projects in the M4P market. So effects of that experience, there was the squeezing out of the private market. This is essentially for the mosquito nets. There was the squeezing out of the private sector market. The consumers also were not primed to purchase the product, because what the initial thinking was, there was free distribution of these products from the government, from donors, and the thinking was, over time, consumers will be primed to buy this product after seeing the benefits of the products that were given to them for free. But that really did not happen. And that brought about reduced incentives for the market players to invest. But we then found out something. Logistics management was a green light. I spoke about theft. Now, what we're then thinking, but unfortunately could not really be done because that came about towards the end of the project, was there are private sector players that are ready to house these products and ready to move these products, can I say, to site, as at the time when they are needed. A government warehouse can easily be accessed by government people and things can move out. However, if you have a private sector person who knows that this thing it's his mandate to keep these products and to secure these products and move them to site whenever he needs so. He needs to do it because if he doesn't get it done right, he doesn't get paid. So we found out that that is something that can be done, and it's something that I think going forward, M4P projects or even regular donors that will be doing distribution, even the government should look at that in order to reduce that pilferage, because then it reduces access of that product to the final consumer. So a possible solution to that, to all those really, communication at that government level. It wasn't really being done. There needs to be that. There needs to be a high-level engagement with the private sector players and clear demarcation of roles. Private sector guys need to know what exactly they're meant to do. The government also needs to know what it wants the private sector to do, and everybody must be clear on that from the get-go. And there must be harmonization interventions, and there must also be political will on the part of the government. For any further information, you can contact me. Thank you very much.
Right, same scenario. Any quick clarifications? 2 minutes.
I just wanted to find out the displacement that the first donor project cost in the private sector, right? Did any of the people that invested in the net for sale, the private investors, were they able to sell? And were they selling only in the urban area, or did they get some entry into the rural area?
Thank you for that. A lot of the sales turned out to be from the urban areas, and for some of these private sector players, they also got to sell to governments, maybe at the lower level, the state governments, and nets are used for free distribution during political campaigns, so they also targeted those. So they actually got to sell, but not as much as they would have really loved, because they really wanted to boost the private sector market for the sustainability that we need.
So there's an elimination of the free nets now. There's no free nets from anywhere now.
There are still free nets. There are still free nets in the country. Private companies, and at times, if you're doing very high volumes, you go direct to manufacturer.
All right. One more? Any more? Any more? Right. Okay. Let's zoom out a little bit. So just some general conclusions that while these projects, we don't have a long time horizon in terms of results at the moment, although SunMap was an 8-year program, we haven't got a huge ex-post impact assessment. But the sustainability is embedded within the programs by design. So whatever results you've got now, you hope that they're going to last in a way that they wouldn't with a direct delivery program. There is also a leveraging of donor investment. As you see, there's through PSP4H, it's not cash that's gone in, and cash has gone in on your side, right? You've had to invest to make this happen. And also something that's not talked about often enough, I don't think, is that when it does work, the value for money for a donor agency is quite significant. Right, so what I want to do now is I've got 4 questions up here, and I want to put them out, and we'll get one answer from the panel, and potentially me if I'm feeling like, because I've got the microphone. And then I want to take one answer from you guys as well, after which we'll go to open questions. But this is kind of less about project specifics and more about general M4P in health. So, panel, that's you guys. Why are more programs not using this approach? Who wants to take it? Oh, you got a second microphone.
Well, interesting. A lot of it's because of kind of health being a politicized area, and typically the health professionals distrust the private sector. So it's a very donor agenda driven sector in terms of development assistance. So almost all the agendas are set externally. So like I said, when we first mapped the sector, we found lots and lots of programs, but they're all crowded in one area. In fact, I saw a memo from a big pharma company trying to engage with DFID just this week, but they're in non-communicable diseases. And the internal corporate memo said DFID's not interested because they're only interested in communicable diseases. So I kind of laugh sometimes, and I say the reason there are not more programs is because it's not the donors' diseases. They're not interested. So it's something that Simon Stevens talked about this morning. It's the political economy of the donor world. So the donors plan externally what they're going to do. We found a huge field to play in that's having a big impact on the poor right away, but it's not on the donor agenda. So our problem is just getting it on the agenda.
You should speak to Sarah Bloom if you see her, because about 3 or 4 years ago, DFID go around and their professional cadres and ask them what they would most like to know about, technically, in their field of work. And about 3 or 4 years ago, the health team within DFID ranked M4P as the #1 thing they most wanted to learn about. So the real question is, if that was the #1 thing, have they learnt about it, and why aren't they doing it?
Yeah, well, that kind of brings us to the next question, actually. I don't know if there's an answer in the audience about this distrust of the private sector within...
To overcome the distrust.
To overcome the distrust of private... I mean, you must have the answer, right?
I know, for me, I think there needs to be more evidence put out there, because from what the PSP4H has done, what SumUp has done, I really believe that I don't really see why there should be, but it's there. Maybe again because of the fact that health might be seen as a public service by a lot of people. You don't want to really, you are looking at people not paying for it. You don't want the poor to pay for it. But if I look at Nigeria, I look at consumer spending patterns. Over the last 10 years, the amount of money people spend on healthcare in general has close to tripled. So it shows that the private sector, I think people can, people are ready to pay for these things. And so when it comes to that distrust, it's just all about a paradigm shift, really. People need put the evidence out there, and I think people can then shift towards it. Yeah.
Okay.
I see a lot of distrust, especially from where we are, where we have the private sector. Basically they want to make money, they want to make profit, and the donor community basically they want to do programs, and they want it's coming free. So what we're doing is as long as you're coming in and you're going to fund programs within my community, and I'm not involved, and you know they're free of charge. What you're doing is you're basically taking my business, really. When that money dries out, what happens is all those people are going to come running to me. I remember we had anti-malarial products that were being sold at less than $1 in Kenya, and once the program runs out, you find the private players are selling them for about $5. And what does that mean? It means then that the community begin to become disillusioned as well, because they no longer trust the product. Yesterday I was buying it at $1. Today you're telling me it is $5 bob. So why should I continue playing?
Mm-hmm.
But I just doubt this question, because is there any distrust about the private sector in health? Because the private sector is very much present in ATM, we call AIDS, tuberculosis, and malaria. It's the private sector which are delivering the commodities to the health sector. The public sector is buying from them, actually. So it's basically them dictating what health indicators should be and how that should be tackled. So the private sector is very much present there. And if you also take into account cases like in Bangladesh and elsewhere, the NGOs, I mean, they have delivered miracles within, let's say, maternal health care and child nutrition and so on and so forth, because they worked with informal health service delivery channels. And that's where they were basically working with the private sector and private health systems. So I think it would be a bit myopic to say that, I mean, the development community is distrusting the private sector, but they see the roles in different ways than they see the role in agricultural systems or in livelihood systems and so on and so forth. Yeah. So it's about understanding the roles in a different way and then leveraging on it to deliver better, let's say, sustainable and scalable results in health systems, I would say.
Okay. Pass it straight.
I mean, I think I agree with that, but I guess my point was going to be that working where you can with the actual private sector who are involved, like the pharmacies and so on, is a really nice place to show impact and the ability to make change happen on a market systems basis. Yeah. So I think that you're doing the right thing, but more case studies like this will show people the benefits.
Well, that
I think you
brings us
can't.
to our next question is, how do we communicate this message?
Yeah.
And I notice we have a communications person in the room, right? So what is the way to get these messages across? Particularly, this is kind of relevant beyond just health, but in all these new fields, you're not going to generate the evidence until you've got programs, and you're not going to get programs until you've got the evidence. So how do we really start to make the argument?
Well, for me, I see this program as very, very similar to a program we're running in the inputs sector in Tanzania, where we're trying to create a network of providers of inputs that's quality controlled, quality assured, that they've got collective purchasing. It's very, very similar type branding and so on.
Agricultural inputs.
Agricultural inputs. Yeah.
So you can link it back with.
It's almost identical, and it's really nice, and I'd like to really spend some time learning from it actually. So from our side, we would love to share this case study with all of our teams about on the private sector input side rather than health.
So maybe that's a sort of a point to move forward. Point to move forward on is that you can sort of use the theory and the evidence from other sectors and use it to demonstrate the practical possibilities.
Yeah, just one thought on that. I mean, we talk about the health system, and that's too big and broad to engage everybody. So if we want to communicate it, certain aspects of the health system have lower information asymmetries and lower negative externalities, which has different incentives for public and private roles. So if we start differentiating this, like SUNMAP, I think, Kabir, you were saying around prevention, testing, treatment, they're all very different market systems with different externalities, different information asymmetries. And there's different license to operate by health professionals, if you like, in different those different areas and different markets within those areas. So I think we need to move from health into what we mean within the health system, take the opportunities where there is less contention, for these reasons, build a body of knowledge in that, and move and progress that forward. So we have to get into specific context, where there is license to operate, build an evidence base, and progress from there. And that means moving the debate from public or private roles in health. M4P is exactly about looking at those market systems and understand the roles of public and private need to be in that context. And I guess with that's one of the learnings, I think, from you, Kabir, and the way you organise SUNMAP going forward, is to not differentiate public and private sector in the components that you run.
Thank you. For that second question, I think it might be the other way round, that it's the private sector that might not trust the development community because they might think they're self-perpetuating with the private sector money. So coming from or representing two private sector organisations, Barclays and GSK, I think there's a shift away from traditional donor programs, more to working in collaboration and partnership, and support totally what you've said about roles for everybody. So I would switch the trust the other way around, probably. Thanks.
All right. Yeah.
Now, again, if you look at what does private sector mean, in Kenya, it's about 62% private sector right now, but that's split between commercial and faith-based and NGO. And our mandate in PSP4H is to look at the commercial sector. So I think in some ways this comment pertains to the commercial sector. We use the term sharks and vultures. When the public sector health people look at commercial sector, they see sharks and vultures circling. Because in health, you have extreme moral hazard. I'm from the US, where we spend twice as much of GDP in health than any other country in the world. It's because the supply side is out of control. So when the public sector and the conventional health, and especially in DFID, because UK has NHS and a very public sector view of the world, they look at the commercial sector as being opportunistic. And if you look at Kenya, for example, one of the reasons the programs work so well is we're supposed to originally look at quintiles. Okay, so I'm an economist, and a quintile is an even fifth of the population. It doesn't work that way. We're supposed to come in and look at the second and third quintiles as the working poor. But that's a Western definition. In Kenya, the second and third quintiles are below poverty. And the so-called growing middle class is really the growing upper quarter of the upper quintile. And that's sort of the big pharma and big hospitals target. So that's the view of the commercial private sector from the donor's chair, is that in Kenya, the commercial private sector is Aga Khan Hospital, where you basically pay a Western rate for a consultation. Okay, or it's the pharmacy, it's the Good Life Pharmacy, which is run by people from Boots, and they're at the shopping malls. But it's not the FarmNet, which basically is a little kiosk with bars on the windows down in the informal settlement. Okay, so we've tried to differentiate private sector projects. Because in the same way, you know, these big, like, investor-driven, capital-heavy PPPs that don't benefit the poor, from the development perspective, that's the same as an M4P program because it's private sector. So part of what we figured out is differentiate, but I think that communication's not there yet. So we're trying to figure out ways to actually get it to the program designers and the decision makers. So we also found, in talking about communication, that if we just take our hundreds of stakeholders and survey them, everyone says great program. But when we segment the market, great uptake from consumers and consumer groups, informal sector, commercial sector, NGOs, FBOs, associations. Now we start getting into government and development partners, the air gets really thin. So we find out there's very few people who actually influence, you know, the program design. So that's actually kind of what we're talking about. How do we break the myth that the private sector is all sharks and vultures and are not worth engaging with?
Okay, we're just going to have to let Kabir, no, we're going to have to let Jesse go because he has to run for his flight. But yeah, quick round of applause on the way out as he exits. Okay. Yeah, everyone, there's at least one more question. So the last question, oh.
Just following up on the point. The point is, when we're talking about health, a big question is about quality assurance, and the distrust from the public health sector or public, health professionals comes from the fact that they think if you are privatizing health, then you are basically not being able to regulate it, and you are also not being able to quality assure the product distribution and so on and so forth. So, I mean, the distrust, if you're talking about, going through the private channels, comes also from quality assurance, and I was really pleased to see in your model that you're presenting, quality assurance was a key part. So if you're talking about breaking the distrust, you have to show the evidence that if you're working with the private sector, then, it's not essentially leading to exploitation of the poor, or it's not essentially leading to counterfeit drugs being traded to the poor because they can't make a decision. So that's an essential part of an evidence base that you have to create to break the distrust you're talking about.
If I can respond to that quickly. No, absolutely, and that's part of the program design. So again, you can have a good strategy and a failed design and implementation. So it's just intelligent program design because all of the networks we work with are already within the regulatory system. So to be a KPA member, you have to be licensed and registered. You have to show your license. In fact, one of the things that made it slow to organize the network is everyone had to bring their paperwork in. Okay, same thing with DocNet. You have to be a licensed consulting physician, LabNet licensed medical laboratory. So everyone in our networks is already minimum level within the regulatory system. And so we leverage that because then they can be even tougher on quality assurance with internal audits and everything else.
All right, last question. When would a systemic approach to intervention in health not work? When is it not appropriate? Oh. Go on.
I'm not saying, I'm looking at systemic approaches that have not worked in this area. And pharmacies, franchise pharmacies, is not new in Kenya either. There was one I remember working with years, I don't know, I'm far too old now, many years ago in Ghana, Care something. Care Shop, I think it was, which had very similar kind of model and aspiration that you've presented here, and worked for a period of time, and then collapsed under the pressure of the franchisee-franchisor relationship. And there were three main factors there around quality issues and different views on quality that they were having from the drugs manufacturers going through the pharmaceutical kind of franchisor, and what the quality, because given there's choice that these people have outside of that network. So quality was a relative issue, and that then linked to competition, that they weren't alone in this, there was competition, and they had to respond to that. And then the compliance costs of the franchisee-franchisor relationship. So that failed. So that was a systemic approach that worked for a while and then didn't stick for a wide range of reasons, often that were beyond the remit of the business model itself. These are external reasons around regulation, enforcement, et cetera, et cetera. So I'm wondering to the extent to which you've learned from failure of some of these other programs that have started up and then lost. And there was, at the time, I remember something in Kenya called CFW FarmNet, who you're putting your thumbs down to. But I think they were established in 1997. I know they're probably not for profit, but I do believe they've opened a for-profit subsidiary these days. So I was wondering if there's any learning from these as well. Maybe if that's a non-systemic approach, how has that performed relative to a more systemic approach that you're bringing about?
Well, the reason I gave the thumbs down to CFW is when I first got to Kenya, I saw that and I said, aha, because my first thought was exactly yours. Is the pharmacy franchise was a quick win, and it was an obvious place to intervene because it's so fragmented in Kenya. So I looked at CFW, and the thing that turned me off to them was when I went to their website and I found about 22 donor logos on it. So basically, my theory is that the reason that donor pilots, or I don't like social franchises personally. They're too social and not enough of an enterprise. And the reason is that the balance sheet gets distorted. So basically CFW could not operate on a commercial basis. If all the 22 donors pulled out, they couldn't operate. And we have other partners who've actually withdrawn from because they get too much donor money. They're not serious about actually turning a profit. And I've written about this. There's a brief on our website about what sustainability means. It means making an operating profit. It means paying your depreciation. It means making a surplus so you can invest. And if you don't have a donor-distorted balance sheet, you can actually scale up. So that's one reason we, by design, didn't capitalize FarmNet. The political economy issues you're talking about, I think are difficult to control. And I think if you've worked in Kenya, you know they're very significant. So we have to deal with that. In fact, we had a board meeting at KPA NTP last week where I was there for 6 hours. People were shouting at each other. Okay, so yeah, you have to manage those issues carefully. But again, there has to be ownership. So we're not going to come in and buy our way into it. In terms of market risk from competition, one of the thoughts on putting this intervention together was, I have a private sector background, and I said, well, let's start with 100. Well, why 100? I didn't do some fancy statistical calculation. I just said, sounds like a good number. That's enough aggregation to get the attention of the distributors and the manufacturers, okay? And I went to one of GSK's competitors, a global company that has a generics line. And I went and made this beautiful PowerPoint for about an hour. And when I got done, there was only one word on the country manager's paper, and it said 103. Because we had 103 pharmacies in the network at that. So all the nice stuff I talked about didn't register. The fact that we had 103 pharmacies in pooled procurement got their attention. So they were the first ones in. They're actually the hidden hero of FarmNet because they said, let's blow away the smoke, let's push through our distribution. And again, we're trying to set up a forward-looking model. So it's an asset light, it's a virtual window where we use the existing distribution. So you know, we're trying to learn from that. We're trying not to invest in assets. We're trying not to distort the balance sheet. We're trying not to disrupt the existing supply chain. And actually what we found is more manufacturers come on now and they're trying to push through. They will offer special prices, but it's only through their distributors. So they're basically saying, you can access this price, but you have to buy through this one or this one. Yeah. Okay. So I think what we'll have to do, Matt put his hand up first, unspoken. So I also have an answer, right? So I have the answer. So hurry up.
but then I didn't quite understand why does FarmNet mention development partners as one of the three stakeholders they deal with? I mean, what prevents FarmNet, or what type of motivations would they have not to take other donors on board and orient themselves towards the donor market in future beyond your program? So perhaps a clarification would be good.
Yeah, I wish you'd asked that like 10 minutes ago while Jesse was still here, because I can only answer by proxy. We can't sit in their shoes, but basically what we told them, we're basically a consulting firm, and it's knowledge that's missing, which they know that. Because like you said, it was their idea. And we've actually been preparing to exit. So what we've brought in is, again, since I have someone working with GSK here, one of your major competitors. Well, we actually have a partnership with GSK in Kenya on another intervention, and they're in the supply chain for FarmNet too. But one of the major global pharmaceutical companies sees the potential. So they're actually putting together a management advisory board because we're planning to transition out in case our funding doesn't get renewed. So there's been a plan in place where we've been temporary the whole time. My fear is just what you're saying, is that, let's say another donor comes in and instead of the market crowding in, the donors crowd in. because they see an easy success to pick up. And then to me, money's fungible, so money from one donor is just as good in your bank account as money from the market. So it's a danger. We're trying to do it in a proper way. And again, the pharmaceutical community in Kenya realizes the value, and especially the global manufacturers that are concerned with quality in the supply chain are trying to manage it so it is sustainable.
There are 2 papers in this book, one on health and one on education, which provide a kind of useful frameworks. I've no idea. I've never met him. But let me tell you, a serious point. So, a Twitter answer, well, I can't. So you'll have to have 5 tweets, right? Yeah, so there are a couple of frameworks in this that help you think through this sort of question about, how many people you want to impact. What are the consequences if you don't impact on them quickly? So there's like a 5-point framework from the education paper. There's another one, and it contrasts sort of, the Ebola crisis. Does anyone think that we should have waited until we develop a local provider of the, the cure for Ebola? So health is a really interesting example here of how you might consider different approaches, and it's not a binary answer. So someone can have this. Who wants this? Hey! I'll just throw it into the crowd. Right, I think we have to finish there because some of us have to catch flights. All right, thanks very much.